First of all the slides I'm about to show you are in your handout. There's going to be a few questions that come up that aren't in the handout, but they'll be interactive questions. The way that I do this talk is I'm going to kind of give you a table of what agents to use and what potential therapies they provide, so that at the end of the talk you'll have a full table that kind of gives you an idea of which agents to use in which situations. Okay, so heart failure is a very impressive disease in terms of its ability to cause mortality. There's more deaths from heart failure than all cancers. 5 million symptomatic patients, 20 million asymptomatic with LV dysfunction. Estimated that this disease will become more common, some 40,000 deaths directly attributable, and 220,000 where heart failure is a contributing factor, and 500,000 new cases every year. Above the age of 80, the prevalence of heart failure is an astonishing 10%. And there is an increasing incidence of heart failure due to the aging population, and because we're taking better care of people with hypertension and coronary disease, they live a lot longer and therefore have heart failure for a longer period of time. Coronary disease is increasing as a factor. There's a relative increase in coronary disease and dilated cardiomyopathy. Systolic dysfunction, so we're going to define that basically as a low ejection fraction, so an ejection fraction below normal, which is usually below 50 to 60% would be considered normal, so below that number. And most heart failure is systolic, about 70% or so of heart failure is systolic, and 20 to 30% is diastolic, where the ejection fraction is normal, but the heart doesn't fill as well. Hypertension and acute ischemia are typical of diastolic dysfunction. We're going to talk about that. Arrhythmias are common, and we talked yesterday about arrhythmias with John DeMarco. He talked about VT being common, and a certain number of deaths, close to half of the deaths in heart failure are sudden, and the other half are due to progressive heart failure. I think it's important to realize that a few years ago they changed the definition of heart failure. We had always thought of heart failure in terms of New York Heart Association class, which was 1, 2, 3, 4. And we'll talk about that, but the American Heart Association and the American College of Cardiology came up with 4 stages of heart failure, A, B, C, D. And the concept here was that, actually, could you reset the timer back there, Jimmy? Because the timer needs to be reset. Stage A, Stage B, Stage C, and Stage D, in order to emphasize the fact that patients develop heart failure and we want to prevent the heart failure rather than allowing them to go on and develop it. So Stage A are patients at a high risk of developing heart failure, so patients who have structural heart disease or myocardial disease or valvular disease are at high risk of developing heart failure and should be followed. Stage B would be they develop structural heart disease, but they don't have any signs or symptoms of heart failure. So these are people who have a low ejection fraction or have a thick ventricle, but they don't have any symptoms of the disease yet. Stage C is a patient who has symptoms of heart failure and has structural heart disease, so coronary disease or dilated cardiomyopathy. And basically class 1, 2, and 3, New York Heart Stage class 1, 2, and 3, would fit into this particular Stage C. And then Stage D is a patient with advanced structural heart disease, marked symptomatology, heart failure at rest. When they just walk around and do normal activity, they're short of breath. and they require maximal medical therapy and potentially specialized interventions in order to treat these patients. So the concept here and what the Heart Association was trying to do was to place emphasis on the patients who might develop heart failure so that we try to prevent heart failure. From the ICU point of view, we see a lot of patients in stage C heart failure, stage 3, New York Heart Association Class 3, and we see people in stage D or New York Heart Association Class 4 heart failure. So this is the heart failure natural history. This is from some years ago, but things have not changed significantly in that period of time in terms of New York Heart Class. So somebody with no heart failure or New York Heart Association Class 1 would be up here. Somebody in Class 2 or 3 heart failure. 2 is somebody who is symptomatic with exertion. Class 3 is somebody who is symptomatic with normal activity. So Class 4 would be somebody who is symptomatic at rest. So at rest is a 4, 3 is with normal activity, 2 is with exercise, and somebody with Class 1 heart failure doesn't get symptomatic except with extreme activity. And you can see that people who have New York Heart Association Class 2 or 3 do worse than people who are asymptomatic. And people in New York Heart Association Class 4, and this would be also the new Class D that I just showed you, have very poor prognosis. And in fact, about half of these patients have died at about 1 year. So very serious disease, considerably more severe than most cancers. One pathogenesis slide just to remind you the consequences of somebody with impaired left ventricular dysfunction. If you have LV dysfunction, it causes a low cardiac output and a low stroke volume. That activates the neurohumoral system, the renin-angiotensin system, catecholamines, increases systemic vascular resistance. The increase in systemic vascular resistance causes an increase in afterload, and the increase in afterload causes more impairment of LV function, and so you get a algorithm here that leads to more and more LV dysfunction. When you get a low cardiac output, you get poor renal perfusion, sodium and water gets reabsorbed more, an increase in blood volume leading to edema in our patients. That also increases preload so that you get a bigger ventricle, left ventricle and right ventricle. That increase in preload leads to mitral and tricuspid regurgitation, and this regurgitation lowers the cardiac output further. So it's a circle that basically we want to interrupt with our therapy, and we have therapies that work at different parts of this particular pathogenetic sequence. Acute severe heart failure has been appreciated more in the last decade or so as something that commonly causes people to be admitted to the intensive care unit. There's a lot of names for this: acute decompensated heart failure, acute pulmonary edema with hypertension, shock, cardiogenic shock, high output heart failure, and right ventricular failure all kind of fit into this particular set of acute severe heart failure syndromes. And so we'll go to question number 1. In acute severe heart failure, which of the following is a poor prognostic indicator? There are a number of poor prognostic indicators, but which of the 4 listed here is a poor prognostic indicator? Hypernatremia, polycythemia, hypotension, or cardiomyopathy versus somebody who has coronary artery disease. So if you could answer now, please. Okay, so 53%, a majority, got the right answer. The right answer is hypotension. Somebody comes in with severe heart failure and they're hypotensive. In general, a lot of those people are in cardiogenic shock. That has a worse prognosis than somebody without hypotension. Hyponatremia, not hypernatremia, is a poor prognostic sign. Polycythemia is not a poor prognostic sign in severe heart failure. And actually, people with coronary disease have a somewhat poorer prognosis than people with cardiomyopathy. So it's the opposite of these. So hypotension is the correct answer, and a majority of you got that. So hypotension. So here are the poor prognostic indicators of acute severe heart failure. As I mentioned, hypotension, systolic under 115, or in general, a systolic down around 90 is the usual finding. If you have coronary disease compared to cardiomyopathy, that's a worse prognosis. This is a very serious prognosis. Heart failure and an elevated BUN. Those people do a lot worse than people without an elevated BUN or an elevated creatinine. Hyponatremia, as I mentioned, hypernatremia is not seen in acute severe heart failure. Low ejection fraction, poor functional capacity, so somebody hasn't been able to get around their house very well before they came in. That person is more likely to die during acute severe heart failure. Elevated BNP or an elevated troponin identifies people with a worse prognosis. So these, in addition to being somewhat diagnostic, are also indicative of a poorer prognosis. Anemia, so not polycythemia, and people with diabetes also have a worse prognosis. So these are important for you to keep in mind because that identifies a group of people who need to be treated particularly aggressively. So what are the causes when somebody walks into the ICU or comes into the ICU, rolled into the ICU with acute decompensated heart failure? What are the causes that you should think about? Excess salt and fluid due to indiscretion or just eating. About a quarter of the people will have that as the major cause. A quarter will have noncompliance. About 16% have adverse medication effects, and it's important to go through the medications. Calcium channel blockers, antiarrhythmics, NSAIDs are three biggies as causes of acute decompensated heart failure, so you really need to identify people who are on those agents and get them stopped in order to help out those patients. Corticosteroids and a number of other drugs as well as alcohol are associated with acute decompensated heart failure. Cardiovascular direct causes of acute decompensated heart failure: acute ischemia, pulmonary embolism, uncontrolled hypertension, arrhythmia, worsening of valve dysfunction. Sometimes acute endocarditis can produce this. Extra cardiac illnesses like sepsis can produce heart failure, hypoxia, renal failure, thyroid disease, anemia. Sleep apnea, another important consideration, and renal artery stenosis in a rare set of cases. Okay, so how should we treat heart failure? And with heart failure, you have a number of different goals in mind when you have a heart failure patient. One thing you want to do for that patient is to improve their quality of life long term. So they're very short of breath. You want to relieve the symptoms of shortness of breath. They've got lousy exercise activity, and you want to improve their exercise activity. So quality of life issues. They've got an ejection fraction that's quite low, and if you can improve that progressive myocardial dysfunction, that would be another good goal for heart failure patients. And, of course, the big endpoint with any disease, really, is to prolong life and reduce mortality. And so we're going to look at basically these three broad endpoints, or four broad endpoints, and see how the different therapies for heart failure fare. One thing to keep in mind is that there are a number of reversible reversible pathogenetic processes that can cause heart failure in your patient being admitted to the ICU. And these reversible processes are things you should keep in mind as first, does my patient have this? Do they have hibernating or stunned myocardium? Do they have sepsis, and the sepsis has a lot of myocardial depression? Or do they potentially have myocarditis? Not a common problem, but can produce acute severe heart failure. In terms of stunned and hibernating myocardium, I have mentioned this briefly in the talk yesterday on cardiogenic shock. Stunned myocardium, the classical example is that you put a clamp on an animal's coronary artery and you get a wall motion abnormality during the occlusion. This occurs within seconds of clamping the coronary. If you have a clot in a coronary, you'll get a wall motion abnormality again within seconds. And then if you restore flow, you put a stent in the vessel or you let the vessel, the clamp off, you still get a persistent wall motion abnormality despite reperfusion and viable myocytes. And you get a gradual return of function. This is called stunned myocardium. And it occurs commonly, and it can produce heart failure. And your patient may have it, and you may need to keep them going for a period of time in the ICU till their stunning goes away, and then they'll be able to kind of handle things on their own. But during that period of time, you have to support them pharmacologically. Now, one example of stunned myocardium that's very dramatic and has been well described in the last 2 decades is the so-called stress cardiomyopathy, originally described as Takotsubo cardiomyopathy after the octopus pot in Japan, because the ventricle looks like that. I'll show you a picture of that. It has a lot of other names, this stress cardiomyopathy: transient apical ballooning syndrome, apical cardiomyopathy, stress cardiomyopathy, stunning due to sudden stress, acute reversible cardiomyopathy. Whatever the name, it's an important consideration because people do develop this, and it is a very common board question these days. Seems to be a very popular syndrome for the board examinees. 94% of the cases that have been reported are in women. It mimics an acute MI with chest pain, dyspnea, pulmonary edema, can have hypotension, cardiogenic shock, rarely can present as an arrest. ECGs have impressive changes. I'll show you some examples with ST elevation or T-wave inversion. There can be an increase in fall of the troponin out of proportion to the degree of LV wall motion. So the wall motion may be very severe and only a little bit of troponin elevation or no troponin elevation. It's not a common disease, but it does occur frequently enough so that you really need to be familiar with it. It's precipitated in most cases by severe extreme emotional stress. A family member died, someone got hit unfortunately by an automobile or something like that. It's been reported with arguments, domestic abuse, death in the family, financial reversals. You get a regional systolic dysfunction involving akinesis, usually of the apex and mid-ventricle, and the hypercontracting basal areas. No coronary stenoses documented at angiography. The wall motion abnormality usually doesn't correspond to a single coronary distribution, and the case reports they have had wall motion abnormalities all over the place, mid-ventricular akinesia and other areas. So it really can occur anywhere. These are 4 examples of cardiograms. ST segment elevation here in V2 and V3 looks like an MI. Look at these very impressive T-wave inversions. ST segment elevation again, and T-wave inversion and ST segment elevation here. So you can get dramatic EKG changes, and this is the classical wall motion abnormality on left ventriculogram. This is the anterior wall, this is the apex inferior lateral wall. And you can see that this area isn't moving at all. So the anterior apex inferior wall isn't moving at all, but the base is contracting very nicely. The original descriptions of this made the point that it looked like an octopus pot on its side. This is a Japanese octopus pot, and that's how Takasubo got associated with this particular syndrome, described originally in Japan. Another example of a left ventriculogram with regional wall motion abnormalities, but no coronary stenoses that can explain this. So stunned myocardium, there are other examples of stunned myocardium that you should be familiar with, but this stress cardiomyopathy is a popular syndrome right now. Hibernating myocardium, atherosclerotic narrowing, and a wall motion abnormality due to chronic ischemia without infarction. And the most classical example, this is from Ramtula, where you have an EF of 37%, an anterior apical wall motion abnormality, and an occluded left anterior descending that supplies this area. And then you do bypass surgery, or you put a stent in the left anterior descending, and several days later the wall motion abnormality is gone. Ejection fraction's gone from 37 to 76% because this was hibernating myocardium that's not dead, but rather not functional. And when you restore coronary perfusion, in fact, the abnormality goes away. So the most classical example of hibernating myocardium leading to heart failure was in this particular study. This is the original CAS study, coronary artery surgery study, published in the 1980s. Passamani was at NIH. And the way this study was done was that they took patients with an ejection fraction under 50% and 3-vessel coronary artery disease, and they either did bypass surgery or they gave them medical therapy. And then they followed them for 7 years to see whether or not doing bypass surgery was associated with an improvement in survival. And it was. The coronary artery bypass surgery patients are in yellow. The medically treated patients are in blue. So the surgically assigned patients did statistically significantly better. And the reasoning behind the CAS study is that patients had hibernating myocardium, so their ejection fractions were under 50%. You treated the hibernating myocardium with bypass surgery, and therefore they lived longer. And that's the interpretation of this. Now, this is a long time ago. This was published 25 years ago. There is a new trial called the STITCH trial that is looking at this same question. It has finished enrollment, and it is going to be reported sometime in the next couple of years, and it will address this issue of hibernating myocardium in more detail. But right now, this is the best data that we've got in terms of hibernating myocardium. So this is the table that I mentioned. Some people call it a report card or a table of therapies of heart failure, and here are all the therapies that we're going to talk about. And we're going to make a judgment as whether or not the therapy improves the New York Heart class. Do they go from class 4 to class 1 or class 3 to class 1? Does their exercise tolerance due to heart failure get better? Does their ejection fraction improve? And does the agent improve survival? So revascularizing, hibernating myocardium, I just showed you the data from the CAS trial. It's the best data we've got at the moment. New York Heart Association class improves, their exercise tolerance improves, their ejection fraction does go up, and based on the CAS trial, their survival improves. And we're going to go through all these different therapies in the next few minutes, and these therapies on the second slide. And I'll again show you the summary, but also show you a couple of slides on the data so that at least you've seen the data, you have a feel for how strong it is. What about myocarditis, inflammatory cardiomyopathy? Is there any data that tells us whether or not treating somebody with anti-inflammatory therapy, in fact, makes a difference? This has been an interest of mine. This is a patient with severe myocarditis, multinucleated giant cell on heart biopsy. The only data on this was a randomized trial that we did at the NIH some years ago where we gave prednisone to half of the patients with cells in their myocardium and didn't give prednisone to the other half. And prednisone did produce an improvement in left ventricular ejection fraction. It actually resulted in improvement in the number of minutes they could go on a treadmill. We didn't randomize enough people because there aren't that many people with myocarditis. We don't know what survival did. But based on that study, we can say that the exercise tolerance does improve, that the cardiac performance, ejection fraction does improve with prednisone for inflammatory cardiomyopathy, but we don't know whether or not it makes a difference in the long term. So symptomatic, it can be helpful, but in terms of survival, we don't know. What about diuretics for heart failure? They are a mainstay of therapy for heart failure. The goal of diuretics is to relieve symptoms without getting a BUN elevation or getting your patient hypotensive. In patients who don't respond to furosemide or butaminide, you can consider metolazone, which works more in the proximal tubule and sometimes will produce a diuresis, or CAVH may occasionally be useful. Although diuretics are a mainstay, they have never been studied in a randomized controlled trial, and therefore, although they improve New York Heart Class and they improve exercise tolerance and they don't improve cardiac performance, your ejection fraction doesn't change, we don't know whether or not they improve survival, but they're a mainstay of therapy, and therefore they're used in essentially everybody with heart failure. What about direct-acting vasodilators? This is the first large randomized trial, the original VHEF trial published in 86 by Jay Cohen, in which he looked at hydralazine and isosorbide, which are both direct-acting vasodilators, versus placebo and versus prazosin, which is an alpha blocker, which actually didn't work. And he showed for the first time that you could improve survival, a lower mortality rate, by giving hydralazine and isosorbide dinitrate, and this is that particular trial. And that brings us to question number 2. 52-year-old woman with a dilated cardiomyopathy and heart failure comes in the ICU with severe dyspnea and weight gain. Arterial and pulmonary artery catheter are placed, baseline hemodynamics are done, and I think you've seen this type of question. The baseline is here, following the drug administration is here, so the blood pressure goes down a little bit, 100 down to 90. The right atrial pressure goes down some, right ventricular and pulmonary artery pressures go down, wedge pressure, occlusion pressure goes from 28 to 15, cardiac output goes from 2 to 2.6, and the urine output goes from 10 to 140. This hemodynamic change is most consistent with the administration of niciratide, dopamine, norepinephrine, angiotensin, or hydralazine. So if you could answer now, please. Okay, excellent. So the correct answer, and 70% of you got it, is niciratide. And why is that? Basically, the findings, let's see if this will go back, yeah. So the blood pressure went down, okay? So therefore, dopamine and norepinephrine and angiotensin are out because all three of those agents would increase the blood pressure, right? And the blood pressure went down. In addition, all the filling pressures go down, the cardiac output goes up, and the urine output goes up. So you need a balanced vasodilator, something that's going to reduce blood pressure and also reduce filling pressures and also produce enough afterload reduction that your cardiac output goes up and your urine output goes up. And the only balanced vasodilator here is niciratide, which is BNP. They're the same. Hydralazine is an arteriolar vasodilator. So when you give hydralazine, you get a blood pressure drop, okay? You get a decrease in afterload, but it generally does not reduce the filling pressures. Now, that's what occurs acutely. If you give it for a few days, eventually, because of the SVR drop, you'll actually get a drop also in the filling pressures. So you want a balanced vasodilator response, and niciratide would be the correct answer. And 70% of you got that. That's terrific. Okay, so BNP, or niciratide, this is what it looks like. Originally isolated from pig brain, so that's why it's BNP, it's brain from the pig, but it's actually secreted by the ventricles of the heart. It's counter-regulatory to the renin-angiotensin system. Elevated BNP, as I'm sure you all know, is very valuable in terms of diagnosing cardiogenic heart failure. Its negative predictive value is very valuable to exclude heart failure and rule in a pulmonary cause of dyspnea. If you give niciratide, this is a study that was done some years ago, basically you get a balanced vasodilator response, and I already showed this, that the pulmonary capillary wedge goes down, the right atrial pressure goes down, and the cardiac index generally goes up. And this study, the VMAX study, was published in JAMA in 2002 by Jim Young and his colleagues, and basically showed that if you give niciratide, you get a decrease in the filling pressure, and niciratide was better than giving nitroglycerin, and niciratide was better than nitroglycerin over a period of 48 hours. Based on this, niciratide was licensed in the United States to treat heart failure. Since that time, there's been some concerns about using it. This is the data about the fact that niciratide, or BNP, is very valuable in the management of acute dyspnea and has a very good ability to differentiate pulmonary from cardiac dyspnea. However, giving niciratide in patients with acute decompensated heart failure has been kind of evaluated by a whole group of investigators. Sackler-Bernstein is one of those. And they found that, in fact, niciratide was worse in terms of worsening renal failure when treating patients with niciratide compared to not using niciratide. And, in fact, they felt that maybe there was an increase in mortality with niciratide. I think that a balanced view is that it doesn't appear to be any better than other vasodilators, and so now it's really used in a refractory situation where you need an agent intravenously. Niciratide can be used just before you're thinking about using intravenous inotropic agents. What about isosorbide dinitrate and hydralazine kind of chronically? This has been studied in African Americans and blacks with heart failure by Ann Taylor and colleagues, and in fact, isosorbide and hydralazine did reduce mortality in blacks with heart failure. So this particular combination, Bidil, is sold as a direct-acting vasodilator that's particularly good in the African American population. Okay, direct-acting vasodilators improve New York Heart Class, exercise tolerance. There's some controversy. Improve the ejection fraction by a few percentage points, and based on the VA trial and also the Ann Taylor trial, it does improve survival. What about ACE inhibitors? Next on the list here. Well, we're going to go to a question. 36-year-old man has a 2-year history of severe congestive heart failure due to dilated cardiomyopathy, EF very low, 20%, increasing heart failure symptoms, unresponsive, admitted for hemodynamic monitoring, and you're shown the following hemodynamics. So once again, blood pressure before and after the agent, really no change. Right atrial pressure goes down quite a bit. Right ventricular pressure goes down. Pulmonary artery pressure goes down. Pulmonary artery occlusion pressure, you can see 28 to 18. Cardiac index, 1.6 to 2.5. And heart rate stays about the same. So again, we're given a list here: minoxidil, hydralazine, furosemide, nitroglycerin, and enalaprilat. Which of those 5 is most likely to have produced this acute change in hemodynamics? If you could answer now, please. Okay, 58%. This is a tough question. It's impressive. So let's look at this. Not much change in blood pressure, a drop in the filling pressures, and drop in left and right ventricular filling pressures, increase in cardiac index, and no change in the heart rate. And the answer is enalaprilat, so the ACE inhibitor. So minoxidil and hydralazine are arteriolar vasodilators. So they would reduce the systemic vascular resistance, increase cardiac output, sometimes increase heart rate, particularly hydralazine, but in general would not lower the filling pressures. Furosemide would lower the filling pressures but wouldn't make the cardiac output go up at all. And nitroglycerin is largely a venous vasodilator, so it would produce a drop in the filling pressures but wouldn't reliably increase the cardiac output. And this is a substantial increase in cardiac output, so nitroglycerin wouldn't reliably do that. So the most correct answer is enalaprilat, and you got that. That's terrific. Okay, so the answer, enalaprilat. So these are the ACE inhibitors. These are impressive compounds. This is the original consensus data showing a reduction in mortality in class 4 heart failure using enalaprilat, and in class 2 and 3 New York Heart Association heart failure. They worked, and this shows you that enalapril, which is the lower line here, the lower mortality, was better than hydralazine isosorbide. So why do we use ACE inhibitors before we use hydralazine and isosorbide? Because it's been shown to be better in terms of reducing mortality. So the ACE inhibitors are not that good symptomatically. They don't improve excuse me, I'm not reading that right. They improve everything. They improve New York Heart Class. They improve exercise tolerance. They don't improve cardiac performance reliably, so their ejection fraction stays the same. But their ability to improve survival is really impressive, and so they're used in everybody we can use them in heart failure. What about the angiotensin II blockers? They work, the ACE inhibitors work here between angiotensin 1 and 2. The angiotensin II blockers work here between angiotensin II and aldosterone secretion or the direct vasoconstriction. These are very good agents. The valsartan trial showed that valsartan was as good as ACE inhibition, so the angiotensin receptor blockers. And the CHARM trial, program with candesartan, another ACE ARB, also showed comparability to ACE inhibition. So therefore, they are certainly an alternative to ACE. As you know, some people don't handle ACE well. You can give them an ARB. And some people who are refractory to ACE, sometimes adding an ARB will be helpful. So the angiotensin II receptor blockers improve in New York Heart Class, exercise tolerance, not reliable. Cardiac performance may be a little better than ACE, a couple of percentage points, and they improve survival just as the ACE inhibitors. What about aldosterone antagonism? Well, one of the surprising trials of the last 2 decades was this trial, the RALS trial, showing that spironolactone, an aldosterone antagonist, in fact, improves survival in people with severe heart failure. and then a plerinone, which is also an aldosterone antagonist, also in people with left ventricular dysfunction after MI, so a low ejection fraction, also reduced mortality in left ventricular dysfunction. So the aldosterone antagonism, either with spironolactone or plerinone, also gets good grades and gets an improvement in survival based on the RALS and that plerinone trial. Now, I put this big K here because there is a danger of giving aldosterone antagonism, particularly along with ACE inhibitors, and getting hyperkalemia. And there was a study in Canada that showed that people on spironolactone and an ACE inhibitor, they had a very high incidence of hyperkalemia. But the truth is that if you watch carefully, you can avoid hyperkalemia, and I think that's something to just kind of keep in mind. Okay, what about beta blockers as the next therapy? What would make you think beta blockers would work in heart failure? Well, people who have very high circulating catechols, this is high norepinephrine, in fact have poorer prognosis in terms of survival, suggesting maybe they got too much catechols circulating. But it wasn't, although it was started out in the late 70s, early 80s in Sweden. It didn't get into the mainstream medical literature until the mid-90s, when carvedilol was shown to be better than placebo in heart failure, and subsequently metoprolol XL was shown to be better than placebo, and it's impressive. The beta blockers and the ACE inhibitors are impressive. They improve total mortality, they improve cardiovascular mortality, they improve sudden death, and they improve death from worsening heart failure. So the beta blockers are impressive in heart failure, and they get pluses all the way across the page in terms of improvement, and a big improvement in survival. What about digoxin? In heart failure, as you know, it has good hemodynamic effects, increases cardiac output, lowers the filling pressure, increases the ejection fraction, and has certain electrophysiological effects that may also be helpful. However, digoxin doesn't improve survival. What it does do is it reduces hospitalizations, so that if you use death and hospitalization as an endpoint, then it becomes statistically significant. One worrisome note is that when they did a retrospective analysis, they found that digoxin seemed to work well in men, but not in women. And when they divided people up, the women actually had a somewhat higher mortality on digoxin. So retrospective analysis, I don't know exactly what to tell you, except that it's, a cautionary tale. And digoxin gets improvement in New York Heart Class, exercise tolerance, and cardiac performance, and no change in survival, with that one caveat about a retrospective analysis showing that women don't seem to respond to it as well as men. What about inotropic agents, milrinone, vasnerenone, dobutamine, things like that? Of course, they improve the hemodynamics. The wedge goes down, the cardiac index goes up if you give milrinone or one of these agents. However, milrinone orally was shown to increase mortality, decrease survival, so that it, in fact, makes you feel better but causes you to die more frequently, probably due to arrhythmias. And so does vasnerenone. In fact, it produces a dose-dependent increase in mortality and reduction in survival. So the inotropic agents are used really only when you need them in order to improve symptomatology, and you have to tell your patient that giving an inotropic agent, in fact, reduces survival long-term, so that you only want to use these relatively briefly while you get your patient on some other form of therapy that has less negative effect long-term. What about diastolic heart failure? Again, hypertension, diabetes, ischemic heart disease, obesity, and sleep-disordered breathing are the clinical setting where you see diastolic heart failure. If somebody has ischemia, we give anti-ischemic therapy. If they've got hypertension, antihypertensive therapy. You want to get optimal weights on people with diastolic heart failure. Weigh them every day. Venodilators like nitroglycerin sometimes helpful. If they go into AFib, maintaining sinus rhythm may be helpful. Avoiding tachycardia, perhaps. Beta blockers help some of these people, and some of these people occasionally are helped out by calcium channel blockers. Whether or not that's due to its ability to lower the heart rate or not is not totally clear, but again, some of these people will respond symptomatically to beta and calcium channel blockers. There is a group of people with heart failure who have sleep apnea, and I'm sure you're familiar with this, and the sleep apnea is contributing to the heart failure. And CPAP, particularly at night, will help out these patients. And there's been a number of studies. This is one that was in the New England Journal about 4 or 5 years ago that showed that if you gave them CPAP in patients with obstructive sleep apnea, in fact, they had an improvement in their ejection fraction. Now, we don't know whether it improves survival, but we do know it makes people feel better, and also it makes their ejection fractions improve. So, in general, that is used as a therapy of heart failure. What about antiarrhythmic therapy? As I mentioned, half these people die of rhythm disturbances. So what about antiarrhythmic therapy for heart failure patients? This is the MUST trial published by Buxton and colleagues, in which patients were randomized in order to prevent sudden death in patients with heart failure. You can see no antiarrhythmic therapy is in the blue. Patients who were treated with electrophysiology-directed antiarrhythmic therapy are in this kind of pinkish color, and that's about the same, no statistical difference compared to no antiarrhythmic therapy. But if you put in a defibrillator, which Dr. DeMarco talked about, you get this big reduction in mortality. So the defibrillator is really what works in patients with heart failure, particularly under an ejection fraction of 30%, but probably also works in people who have evidence of ventricular arrhythmias under 40% ejection fraction. So the defibrillator is the big agent here. This is the definitive trial, the SCUD-HEF trial, in which ICD therapy was shown to be superior to placebo and superior to giving amiodarone, our best antiarrhythmic agent. So therefore, antiarrhythmic therapy in heart failure patients really consists of putting in an implantable cardioverter defibrillator. Doesn't do anything for the physiology, doesn't make the cardiac performance any better, but it improves survival. It improves survival, and it improves it impressively. And so should be used to prevent sudden death in patients with heart failure and low ejection fractions. Now, there are a number of mechanical support devices that are being used more and more that you should be familiar with. One is cardiac resynchronization therapy, or CRT. Biventricular pacing is another name for this. And then there are a number of ventricular assist devices that are being used now for destination therapy. These were only used to bridge to transplant, but now are being used as destination therapy. And again, some familiarity with them just to get an idea of where they stand. So a patient who has a wide QRS complex, basically, this is a wide QRS complex, so the QRS duration, the number that's used is 120 as the cutoff here. Wider than 120 milliseconds, or 0.12, has a ventricle that is dysynchronous. So instead of the ventricle kind of squeezing, like this, the ventricle is squeezing one wall and then the other, one wall, then the other, so it doesn't synchronously contract. However, if you put in a wire into the left ventricle to pace and the right ventricle, you can actually narrow the QRS complex and do biventricular pacing. And the big thing that happened was that we learned that we could put a catheter into the coronary sinus, push that wire all the way out the coronary sinus onto the left ventricular myocardium through the venous system and capture the left ventricle without putting a wire in the left ventricle, which has the problem of clots and things like that. So this is a wire in the right atrium, a wire in the coronary sinus, a wire in the right ventricle. You do biventricular pacing, and it really is an impressive form of therapy. This is looking at 6-minute walk distance in the InSync study, which is looking at the biventricular pacemaker, or CRT, therapy, and they can walk more. They have a better quality of life out to 12 months and multiple years. They have an increase in their New York Heart Association functional class. They have an improvement in their ejection fraction. And then a study was done in Britain in which they put a biventricular pacemaker in patients without an ICD. They're commonly used together, biv-pacer and ICD, but this was done without the ICD, and they still got an improvement in mortality. So therefore, the CRT, or biventricular pacemaker, gets the full pluses all the way across the board. It improves your New York heart class, exercise tolerance, cardiac performance, survival. About a third of patients have a wide QRS complex and are a candidate for cardiac resynchronization therapy. And this is an excellent form of therapy, improves survival and improves symptoms, and should be considered. What about ventricular assist devices? As you know, balloon pumps can be used really only for a few days, maybe up to a week. We've got other biventricular assists that are commonly used after surgery, the Biomed ventricular assist device. And now we've got several devices that that are left ventricular assist devices that can be implanted, that can be hooked up to an electrical circuit or a mechanical circuit, and can lead to improvement in symptomatology and survival in end-stage heart failure. We've got one survival study, that's this study, the REMATCH study. Eric Rose published this study where left ventricular assist device was put in people with severe end-stage heart failure. This is late class D, late class 4 heart failure, and these patients did do statistically significantly better. Obviously, eventually these people commonly die of their disease, but nonetheless it improved their survival and their quality of life. And these devices are getting better and better. This is a recent paper in the New England Journal from last year, in which continuous flow left ventricular assist device was compared to pulsatile flow, so somewhat different type of device, and the continuous flow device seemed to improve survival. And a number of these are now available and becoming available either on protocol or, in fact, the LVAD from the REMATCH trial has been improved, and it's available for destination therapy. So these agents, I think we're going to look to these agents as more and more common in the future. They're also going to get cheaper. They're going to get less expensive as the technology gets upgraded. They improve symptoms, and based on the REMATCH trial, they improve survival. Finally, cardiac transplantation can only be applied to a small number of people because of donor issues. Been an improvement over the decades in survival. Right now, a good transplant program, 1-year survival, should be about 90%, 92%, something like that, if you're doing enough heart transplants. The big problem is that the number of donors peaked some years ago and is actually plateaued now. There's about 1,500 to 2,000 heart transplants done in the U.S. every year, about 3,000 to 4,000 in the world, and there will always be a limitation. The assumption is that there are about 40,000 to 50,000 people with end-stage heart failure, but only 2,000 will get transplants. So we need other devices, and that's where I think these ventricular assist devices come in. So transplants work. They make you feel better and probably improve survival, although there's never been a randomized controlled trial. Finally, just kind of the future, vasopressin antagonists on top of all the other therapies we had, tolvaptan, which is an aquaresis agent through a vasopressin antagonist. This is a study by Mike Giorgiati in which he showed that there was some improvement in weight after 24 hours and maybe some symptomatology improvement with these agents, not at the level that the ACE inhibitors or beta blockers are able to produce. So some summary slides, principles of heart failure management. Maximize the dose of beta blockers and ACE inhibitors when feasible, careful outpatient titration, daily weights to adjust diuretic dose, monitor adherence with therapies, education, very, very important, of patient and caregivers, improve access to care on a regular basis to prevent people from being admitted to the ICU, and all evidence-based heart failure drugs and device management needs to be given to these people. In terms of drugs, proven morbidity and mortality benefit, beta blockers, ACE inhibitors, ARBs, aldosterone antagonists, and isosorbide and hydralazine. Improve symptoms, but no proven mortality. I showed you the data on DIG. Niceratide, again, in people who have failed other things. IV vasodilators. Inotropic agents, do our best not to use them or use them only briefly. And then a final summary slide, kind of a way of thinking about the asymptomatic to the very severely symptomatic patient, and all the different therapies, ACE inhibitors and beta blockers for everybody, aldosterone antagonists next, and then things like DIG, hydralazine, isosorbide, inotropes kind of last. And we ought to start thinking about these biventricular pacemaker devices, or CRT, ventricular assist devices for people who are appropriate candidates and transplants for the small numbers of people commonly who are younger and who can have a transplant for a number of years. Okay, that's a review of a big topic, but I think an important topic. We've got about 4 minutes left. I'd be happy to take any questions. Thank you very much for your attention. Yes, sir.